A single pill of Ozempic costs $5 to manufacture. In the US, it retails for over $900 a month. The pharmaceutical company's explanation? Research costs. The real answer is far more disturbing. In March 2024, researchers from Yale University, King's College London, and Doctors Without Borders published a study in JAMA Network Open. And what they found was almost too absurd to believe. They calculated the exact cost to manufacture Ozempic, one of the most prescribed, most talked about drugs in the world. The active ingredient, 29 cents per month. Add 15 cents for other chemicals, another 20 cents for the injection pen. Total manufacturing cost? Under $1 per month. Their conclusion? A 1-month supply could be sold profitably for as little as 89 cents to $4.73, including the manufacturer's profit margin. Novo Nordisk's U.S. wholesale price for that same supply? Between $935 and $969 a month. And for Wegovy, the higher dose version of the identical molecule, just rebranded for weight loss, $1,349 a month. Manufacturing costs represent less than 1% of what Americans actually pay. Senator Bernie Sanders said it plainly. Today, a Yale study found that Ozempic costs less than $5 a month to manufacture. And yet, Americans are charged nearly $1,000 a month, while the exact same product can be bought for $155 in Canada or $59 in Germany. But here's what I need you to understand. Ozempic is not the exception. It is the rule. According to a major RAND Corporation analysis for the U.S. Department of Health, American drug prices across all medications are on average 2.78 times higher than in comparable countries. Americans pay at least 22 times more even after accounting for rebates and discounts. Insulin. U.S. prices are nearly 10 times higher than in 33 OECD countries. Spiriva Respimat, a common inhaler for chronic lung disease, over $120 per dose in the U.S. versus around $1 in Canada. The blood thinner Xarelto, 5 times more expensive in the U.S. than across the border. 82% of Americans across all political parties believe prescription drug costs are unreasonable, and over 80% point to pharmaceutical company profits as a major factor. They're not wrong, but the mechanics of how this happens, that's the part that almost never gets explained. Because it isn't one thing, it's a system, a deliberately constructed, legally protected system, and it starts with the patent. When a drug company develops a new medicine, it receives a patent 20 years of exclusive market rights, during which no generic competitor can legally enter. The logic made sense. Give companies time to recoup R&D costs and fund future research. The problem is that the system has been systematically gamed through a practice called patent evergreening. Here's how it works. Instead of letting a patent expire and welcoming competition, companies file new patents not on new drugs, but on tiny tweaks to existing ones. A new pill coating, an extended release version, a slightly different dosage, switching from a pill to an injection. None of these changes require proof of a therapeutic advance. They just need to meet the basic novelty criteria. The result? A drug that should face generic competition gets surrounded by dozens of secondary patents, what critics call a patent thicket, locking out cheaper alternatives for years, sometimes decades, beyond the original exclusivity period. Novo Nordisk's semaglutide patents in the United States extend all the way through 2032. That's why, in countries where those patents have already cracked India, China, Canada, Brazil saw their first legal expirations in April 2026. Generic semaglutide can now be distributed for as little as $28 to $140 per year, a 98% discount. In the U.S., still waiting. And when Congress tried to do something about it in late 2024, Bipartisan negotiators included patent thicket reform after PHRMA, the pharmaceutical industry's main lobbying group, spent $31 million on lobbying in 2024 alone. But this wasn't even the craziest part of how generics get blocked. Even when a generic company challenges a patent and might win, the brand name manufacturer has another tool: pay to delay. The setup is almost elegant in its corruption. The brand name company simply pays the generic competitor often hundreds of millions of dollars to delay entering the market. It settles the patent litigation by handing money to the very company that was about to undercut them. Both sides walk away richer. The only losers are the patients. The FTC has documented this practice extensively, and while a 2013 Supreme Court ruling said it could be challenged under antitrust law, the deals have continued. Because even with legal risk, the math still works for companies who can charge $969 a month for a drug that costs under $1 to make. And sitting quietly in the middle of all this, most people have never heard of. The hidden middlemen, they're called pharmacy benefit managers, or PBMs. 3 companies, CVS Caremark, Express Scripts, and Optum Rx, manage prescription drug benefits for over 270 million Americans. Their job, in theory, is to negotiate lower drug prices on behalf of insurers. Here's the mechanics. Drug manufacturers pay PBMs large rebates to get their drugs placed favorably on insurance formularies, the lists of covered medications. To fund those rebates, manufacturers raise their list prices. Patients with high deductibles who pay based on list price, not the negotiated price, end up paying more. The PBM takes its cut. The manufacturer raises its price to cover the rebate, and somehow, the people filling prescriptions never see the savings. The PBM lobby spent nearly $18 million in Washington in 2024 just to keep things exactly as they are. The pharmaceutical industry has one answer to all of this: we need the revenue to fund research. New drugs cost $2, $6 billion, and 10 to 15 years to develop. If you cap our prices, you kill innovation. There's genuine truth in this. Drug development is expensive and risky. Small biotech companies do extraordinary work on genuinely thin margins. But for the large players, the numbers don't hold up. In 2020, 7 out of 10 of the biggest pharmaceutical companies spent more on sales and marketing than on research and development. The excess of marketing over R&D for those 10 companies? $36 billion. Pfizer's breakdown, 33% of revenue on sales and administrative costs versus 14.2% on R&D. When the 2017 Tax Cuts and Jobs Act handed pharmaceutical companies a major windfall, their payouts to Wall Street and board members were 17 times larger than their increased investment in research. And a 2025 Science Direct analysis of the 11 companies selling drugs subject to Medicare price negotiation found they generated $2.5 trillion in revenue from 2019 to 2023, with profit margins exceeding their reported R&D costs. The study's conclusion was unambiguous. Reducing revenue from these drugs would not limit funds for operations or required returns on investment. The molecule in Ozempic, semaglutide, is now on the World Health Organization's essential medicines list. It reduces kidney disease, prevents major cardiovascular events, and lowers all-cause mortality in high-risk patients. In other words, it saves lives. In countries with functioning price controls, you can get it for under $150 a year. In the United States, where Medicare was legally banned from negotiating drug prices for most of its history, where the lobbying machine spent $372 million in 2024 to preserve this exact system, it costs $11,000 a year. The story of American drug prices isn't a story about research. It's a story about patents that never expire, competitors who get paid to disappear, middlemen who profit from opacity, and lobbying that has made all of it extremely difficult to change. The drug costs 89 cents to make. You're paying $969. Somewhere in that gap is a lot of money, a lot of power, and a lot of people who benefit enormously from the fact that most Americans still think they're just paying for science.